We are back in the TV studio here at the UEG Week 2019 in Barcelona, and I'm delighted to introduce to you my next interview guest is a local matador, so to speak. you are Jordy Bruix. Did I pronounce it correctly?
Correctly.
That's a very interesting name. You are a scientific director, Cyberret.
Yeah.
That is head of the Barcelona Clinic Liver Cancer Group. Yep. Here at the University of Barcelona. And your opening presentation is titled Hepatocellular Carcinoma, from Orphan Disease to a Trendy Topic. That's an interesting title. Tell us a little bit more about it, how you found this title.
The idea of the title was to make it appealing, because frequently it is thought that liver cancer or hepatocellular carcinoma is, let's say, not existing in the West. And for decades, when I was a student and even a resident, it was said, do not need to pay attention to liver cancer. It only affects people in Asia or in Sub-Saharan Africa. And this is not the case. Liver cancer affects all the patients that have long-lasting disease due to different etiologies, viral hepatitis, alcohol intake, and so on. And liver cancer exists all over the world. And now it is known that this is one of the main causes of death in patients with chronic liver disease, and the interest has primed to develop clinical practice guidelines, research, and the field is completely different now from what it was 30 years ago. And this is the reason for the title.
Within the course of the recent years, there have been quite a range of anti-cancer drugs and biological therapies available. Do you think there is even more reason for hope for the near future, that we can be more optimistic about future treatments in that field?
First, one has always to be hopeful. And what is needed is to make research to accomplish this hope. Let's say until 2007 there was no systemic therapy that would provide a survival benefit to patients with liver cancer. In 2007, I was the PI of the trial that showed the benefit of sorafenib versus placebo, and this was let's say, a landmark study that showed that effective therapy for HCC was possible. Then we had 10 years of failures, and now we have a series of positive trials, both in first line and second line, and this shows that HCC can be treated, the treatment can be effective, and not only effective, but safe. So now that we have effective agents for first, second, and third line for HCC, what we have to do is to further expand these benefits, probably move to earlier phases of disease. We do not have any adjuvant option that is effective in preventing recurrence of the disease. We do lots of mechanical intervention, surgery, ablation, chemoembolization, and we need to have an option to reduce the recurrence of the disease or the progression of the disease after such intervention. And this is, I think, will make a big change in the future. Rather than to work in a very advanced phase, move earlier, and this will be the real change with a big impact in the outcome. Okay. And obviously prevention. Prevention would be the first thing.
And this optimistic view into the future, do you think this holds true for other rare hepatic diseases? Yeah,
there are several rare hepatic diseases. I would concentrate now in just the rare tumors. There is a second tumor that is quite frequent, and the incidence is growing, that is intrahepatic cholangiocarcinoma. And this disease, I would say, is in the same situation as HCC 20 years ago. So the incidence is growing, everybody looks with dismal expectations to the disease, but we now have more molecular knowledge, better options, and this is really an entity that deserves major interest. But then we have very infrequent hepatic tumors, angiosarcomas, hemangioendotheliomas, and all these tumors that are really into the rare entities, and we are leading one of the groups about rare tumors, and this is something that will allow international multi-center studies to increase the knowledge in these entities that normally are not so appealing for industries and research consortiums.
And can you probably just in a nutshell tell us what advancements have been made in terms of early diagnosis of hepatocellular carcinoma or other hepatic diseases?
As I said, years ago it was said that it was impossible to diagnose HCC at an early stage. The development of ultrasound and the expert application of it has allowed the detection of tumors at an early stage in more than 60% of the patients if they are enrolled in screening programs. And the target population is patients with cirrhosis of any etiology that would be treated for HCC if diagnosed with HCC. This message is important. The other message that is important is that HCC can be diagnosed confidently by imaging criteria, and the imaging criteria are validated, established, and known everywhere. So there is no need to obtain a biopsy to engage in treatment. If the pattern is specific, no need. If the pattern is not specific, you need a biopsy. And then you can proceed with transplant, resections, ablations, and all these treatments that improve survival. But clearly, this has to be done in expert centers, because the knowledge of HCC is not so wide, the disease is not so common as colorectal, and this makes it really important to have patients attended in multidisciplinary teams where they blend clinical care at the standard of care with research to improve the standards. And this, I think, it's the best advice I can give.
Do you think biomarkers will play a crucial role?
They should play a role, but up to now, the only biomarker that has shown something in HCC is alpha-fetoprotein, but this is really not good for early detection because it's a marker of advanced disease, and there is a drug named ramucirumab that is effective in patients that have increased AFP. Why this is the case and the mechanism is not known, but this would be usefulness of this biomarker. And this is it. We need biomarkers for early diagnosis, for prognosis, and for prediction of efficacy of different drugs.
Like in many other diseases as well, don't we?
But now we are a bit late in molecular profiling, but the point is that now everybody accepts that the tumor is heterogeneous. Most of the samples we have come from early stage, and even what we say early, it's, I would say, a bit advanced. So the tumor is heterogeneous, there are different molecular profiles in different areas of the tumor, and along the evolution this also changes. So probably the hope has to be placed in liquid biopsy or any kind of technology that avoids the failures of biopsy and detect the targets that can be prosecuted by the treatments. But this is research, and right now there is no biomarker in tissue or in blood that can be used to define a treatment for a given patient.
Jordy, thank you very much for stopping by. It was nice talking to you.
My pleasure.
Enjoy your time in Barcelona.
Yeah,
it's your
I
hometown.
live here. I live here in Catalonia. Thank you.